Good morning, everyone. Welcome again to our E&N Add-on Complexity Code G2211 webinar. My name is Ashley Decoto, and I am a specialist with our Provider Outreach and Education team. On the call with me today is my friend and colleague, Leanne Foster, who will be helping out with the chat. We will have a recording of this session available in the Training Center on our website for the next 60 to 90 days, barring any technical issues with the recording. And you can access this without having to access YouTube, as we do recognize that not everyone is able to access YouTube from work. The recording will also be available on our YouTube channel as long as the information remains relevant and current. Also in our training center, you can find a copy of today's presentation, which is still available for download in case you would like to have the presentation to follow along or take notes, though it's not required. We are taking questions through the chat today, which again, Leanne will be monitoring. I will check in with Leanne at the end of the presentation, time permitting, for any unanswered questions in the chat, but we did have a large number of questions that were pre-submitted with registration, and I will be answering those throughout the presentation today. Please keep in mind that we do not have access to claims, so you will need to contact customer service with any claim-specific questions. All right, here's our agenda for today. We will be discussing appropriate use of the add-on code G2211. We'll talk about who's eligible to submit this code, and I'll be sharing some resources. Again, I'll be answering questions that were pre-submitted with registration throughout the presentation. We had a few pre-submitted questions asking about updates. We do have an update, which I will be covering on slide 5. If you've downloaded the presentation from the website, please be sure to make note that there will be a small change to slide 5 and slide 10. And I did email the updated presentation to those who had registered as of about 9:30 Eastern Time this morning. This slide contains the acronyms that we will be using today, and I've gathered these all in one place so that you have this for reference. So let's start off by defining the add-on code G2211. One question asked if Medicaid and Medicare both pay for this code. While we can't speak to Medicaid coverage, this is a payable code for Medicare. For certain evaluation and management services, add-on code G2211 can be billed to account for the intensity and complexity inherent to the evaluation and management visit. So here's how CMS defines this code. G2211 represents a visit complexity inherent to evaluation and management associated with medical care services that serve as the continuing focal point for all needed healthcare services, or with medical care services that are part of ongoing care related to a patient's single serious condition or a complex condition. Then the official definition also indicates that this is an add-on code to be listed separately in addition to certain evaluation and management visits, new or established. And that full definition can be found in the Claims Processing Manual, Chapter 12. I did include a link to that towards the end of our presentation on the resource slide. So for this code, the relationship between the patient and practitioner is really what you want to look at. There must be a longitudinal or a long-term relationship between the patient and practitioner. If you are the focal point, you are the one who the patient looks to for all of their healthcare needs. So for example, you're the primary care physician and you see the patient, let's say at least once a year, but if they get sick, you're the one that they call. Based on that longitudinal relationship, you are able to provide care that is personalized to that patient. Now, for a single serious condition, The patient has a primary care physician, but let's say you are treating their cancer or their epilepsy, for example. For a complex condition, like with a single serious condition, the patient has a primary care physician, but is also being treated for, let's say, pain, to give an example. The treatment of the pain is complex, for example, because of a previous drug addiction. So your documentation would need to show not only that relationship, but in this case, the factors that complicate this condition or make this condition complex for this patient. One pre-submitted question asked what needs to be documented to support the complex care portion in addition to the ongoing care and what makes the patient complex. So if you're meeting the requirements for G2211, because you are providing treatment for a complex condition, your documentation will need to show what it is that makes this condition complex for that patient. And really there's no one size fits all for this because it can be specific to each patient. Like with the example I gave, the treatment of their pain was complicated because of that patient's history with drug addiction. For the ongoing care portion of this question, how long has your provider been treating or expects to continue treating the complex condition? That should also be included in the documentation. Next, these are the primary codes that G2211 may be billed with. First, we have the office or other outpatient codes, 99202 through 99205 for new patients, and 99211 through 99215 for established patients. Now, you might notice a change on this slide from the presentation on our website. CMS added in the 2026 final rule that G2211 is also now payable with E&M home service codes 99341 through 99350, which includes both the new and the established patient home visit codes. And they recognized that building trust in a longitudinal relationship may also be significant in the context of home visits. And I did ask Leanne to place a link in the chat to the 2026 final rule summary, which again is what announces this change. So this add-on code is not applicable with other evaluation and management services, such as emergency department services, nursing facility care, inpatient services, etc. It can only be used with the codes that are listed here. We had a pre-submitted question asking if this can be used with other codes, and the answer to that is no. Again, it's only payable as an add-on code with the E&M services you see here. G2211 is not billed based on the complexity of the visit, but based on the relationship. And it does not make a difference if you choose your E&M level of service based on time or based on medical decision making. Again, this procedure code is about the relationship that you have with that patient. And I will talk a little more about that relationship on the next slide. So you may have noticed here that there are new patient codes. G2211 can be billed in addition to a new patient code, but make sure your documentation supports that the G2211 requirements are met. So let's give an example. A new patient comes to you and explains that they're transferring care to you as their primary care provider. You are starting out care for this patient and will be the focal point for all of their healthcare needs. Or it could be a situation where a specialist will be providing ongoing care for a single serious or a complex condition. So even though a patient might be brand new to you, you can still add this code if you are anticipating that you're going to continue to follow this patient as their focal point of care or continue to treat a single serious or complex condition. All right, next This slide talks more about the relationship. There must be a longitudinal or a long-term relationship between the practitioner and the patient. And this is whether you are the focal point for all healthcare needs or providing ongoing care for a single serious or for a complex condition. And there was some confusion where some were wanting to combine these three things as the requirement for G2211. And you don't need to be all three. You must have a longitudinal relationship with the patient and then meet one of our three options. So you would be either the focal point of care or providing ongoing care for a single serious condition or providing ongoing care for a complex condition. A CMS FAQ tells us that this code would not be used if the relationship with the patient is of discrete, routine, or time-limited nature. And then they give the example of a mole removal or counseling for seasonal allergies. So if you're just seeing them the once for an acute condition and not planning to see them again, this does not meet the longitudinal relationship requirement. We had several pre-submitted questions asking what diagnosis this code can be used with. CMS gives some examples of a single serious or complex condition, such as sickle cell disease and HIV, but these are just examples. There is not an all-inclusive list of conditions or a list of ICD-10 diagnosis codes. The documentation would need to support the ongoing relationship with the patient as the focal point or to treat a single serious or complex condition. One question in particular asked what constitutes a single serious condition, and they give the example of obstructive sleep apnea with obesity and hypertension. So the example given in this question very well could meet the requirements for G2211 if there's that longitudinal relationship and the documentation supports it. So the OSA on its own might be a single serious condition, or managing the obesity might complicate treating the OSA. So in the example given in this question, it really boils down to documenting that you have that ongoing relationship to treat either a single serious condition or a complex condition. Are you, or is your provider, the one primarily responsible for treating that OSA? Or on the other side of it, maybe you are their primary care provider and meet the requirement not by a single serious condition, but because you are that patient's focal point of care. This is really about the relationship and cognitive load in the continued care of that patient. We have also been asked how long must they be a patient to meet the longitudinal requirement. And CMS has not defined longitudinal in terms of length of time, so the documentation will really need to show the relationship. And that is addressed in a CMS FAQ, and we did provide a link for you at the end of the presentation. CMS also gives examples of a longitudinal relationship in an article on how to use this code. And I've also included a link to that article on the resource slide. But one example given is a patient coming in to their primary caregiver for a sinus infection. As the patient's primary care physician, they're able to determine the best course of action based on what they know about that patient. So G2211 captures the complexity and the cognitive load in the continued responsibility of that primary care practitioner as the focal point of that patient's health care. So the complexity here is not in the condition, in this case, the sinus infection. That practitioner has a longitudinal relationship with the patient and is best able to communicate recommendations in an effective manner, which also helps to build that continued, trusting longitudinal relationship. One more example of this relationship is, again, a patient with HIV who comes in to see their infectious disease physician. Because you have a trusting longitudinal relationship with them, they're comfortable admitting to you that they've missed several doses of their HIV medication. And you communicate with them that it's important not to miss doses, but you communicate it in a manner that makes the patient feel comfortable and safe in sharing this type of information with you going forward. So in this case, you have the appropriate relationship and you are treating a complex condition and may bill G2211 in addition to your E&M code. I know that's a lot, but the relationship is super important for G2211. All right, so next, you will have situations where the relationship with the patient will change. For example, you're no longer the focal point, or the patient no longer has a single serious or a complex condition. In those cases, you would no longer bill G2211. One question we were asked was, if a patient has a long-time relationship with the provider, how can the complexity be justified if their chronic conditions are stable? The answer to that is, if the provider is still treating the patient for that complex condition, G2211 can still be appropriate in addition to the E&M code. Remember, billing of G2211 is not based on the complexity of the visit, but based on the longitudinal relationship. Now, if your provider in this situation is no longer treating that patient for the complex condition, then G2211 would not be appropriate. All right, next up, we have provider specialty. CMS has not restricted use of G2211 to any particular specialty, though there may be specialties that are more likely to bill this code. For example, radiologists are probably not going to use this code, or specialists providing one-time treatment for an acute condition would not bill this code. But you would expect to see your family care practitioners using this code when appropriate. Or another example CMS gives is that infectious disease physician who's providing the ongoing care for a patient with HIV, which is a single serious condition. Another example might be a neurologist who has a long-term relationship with a patient that they're treating for MS. They may be able to bill this code in addition to their E&M code. So anyone who's able to bill those evaluation and management codes that we talked about a few slides ago is able to bill G2211 as long as the requirements for the add-on code are met, which again are that longitudinal relationship where the practitioner is either the focal point for all healthcare needs or providing ongoing care to treat a single serious condition or a complex condition. One question we're asked about is, what about situations where providers substitute for one another? Let's give an example. What if Dr. Geller is the focal point, but Dr. Geller is out sick today? Dr. Green is seeing them, or nurse practitioner Phoebe is seeing them in Dr. Geller's absence. CMS understands that a patient may have an ongoing relationship with a patient care team within a group practice, meaning that team-based care practices may serve as the focal point of care, which is one of our qualifiers to meet the definition of G2211. So in the case that a patient sees another physician or practitioner within your group for a team-based care practice, the patient goes to that office as their focal point of care, and it may be appropriate to bill G2211. And that information is also addressed in the FAQ I mentioned earlier. Another question submitted with registration said, we are a PCP office and noticing that specialists are billing for it. Are we able to still bill if the specialists are? And the answer is more than likely yes. You could have situations where a PCP is billing this code because they are the focal point of care, but you also have a specialist who's billing this code because they are providing ongoing treatment for a single serious or a complex condition. Now, having two physicians of the same specialty treating the same condition is a different story. You likely would not both meet this requirement. But for a PCP and a specialist, this could absolutely happen where both are able to bill G2211. Practitioners eligible to submit G2211 include those listed here on this slide. And this would be those eligible to submit the E&M codes, including an MD or DO, a non-physician practitioner, such as a nurse practitioner or physician assistant. This does also include critical access hospitals using method 2 with bill type 85X. Now, rural health clinics and federally qualified health centers, or RHCs and FQHCs, can submit this procedure code on your claim, but there is no additional reimbursement for RHCs and FQHCs. It would be part of your cost reporting. We had a question asking if a psychiatrist can bill this code. While there isn't a limitation on provider specialty, remember that G2211 is only billable as an add-on code with office and outpatient, and now the home visit E&M codes. So if a psychiatrist is billing one of those E&M codes and meets the G2211 requirements, then yes, they could bill this code. Keep in mind, though, that G2211 is not payable with psychiatry codes. So if the psychiatrist is billing those, G2211 would not be payable. We've also been asked if G2211 can be billed with acute visits. And the answer to that really depends. If you're a primary care practitioner, meaning you're the patient's focal point of care, then yes, you could bill G2211 as an add-on, even for an acute visit. Now, for an acute visit in, let's say, an emergency department situation, G2211 would not be billed because the requirements for a longitudinal relationship and being either the focal point or treating a single serious or complex condition are probably not met. And emergency department visits are not one of our primary E&M codes that this can be billed with. Another question asked, if a family practice provider can use this for a visit of a normal, healthy patient where they are the PCP, but not managing any chronic conditions. And the answer to that is yes, absolutely. This code is probably most used by primary care physicians who are meeting the requirement by having a longitudinal relationship with the patient as their focal point of care. Remember, you do need to have the ongoing relationship with the patient plus one of three things. You're either the focal point or treating a single serious condition or treating a complex condition. You do not need to be the focal point and treating a single serious condition and treating a complex condition. You need one of those things and then the relationship. All right, next, the place of service codes are listed here, and these are places of service that would be appropriate with the associated E&M code. So this includes 02 and 10 for telehealth, 11 for office, 19 for outpatient off-campus, and 22 for outpatient on-campus hospital. We have also included the addition of places of service that could be used for home services, including 12 for the patient's home, 13 for assisted living facility, 14 for group home, 33 for custodial care facility, or 55 for residential substance abuse treatment facilities. Leanne will be adding a link in the chat for a page on our website with a list of place of service codes, which includes the descriptions for each of these codes in case you need that for reference. So you're going to use the same place of service for G2211 that you use for your E&M code. Next, there are no frequency limitations for billing G2211. So you can bill this code in addition to your evaluation and management code, as long as you have that longitudinal relationship with the patient and you are the focal point of care or treating a single serious or complex condition. So if you meet the requirements, you can bill it. One pre-submitted question we received is, should providers use this code every time they have an office visit with an applicable patient? And is there frequency guidance on this code? And the answer to that is yes, you could use it every time if the requirements are met. So if you have the longitudinal relationship and you're the focal point or providing ongoing treatment for a single serious or complex condition, you could bill this with each E&M service. Another question we've been asked is if G2211 can be billed when prolonged care is billed. And the answer to that is yes. G2211 may be billed in addition to your E&M code, even when prolonged care is billed. CMS does not have any restrictions on using this code when prolonged care is also billed. We also had a pre-submitted question which asked if you can bill G2211 with multiple units. Now, if this question is asking if you can bill the claim with more than one unit of service for G2211, no, I am not aware of any situation where that would be appropriate. But it may be that who asked this question is confusing G2211 with G2212, which is a prolonged care code that can be billed with multiple units of service. And we do have a video that focuses on prolonged care on our YouTube channel if the person asking this question was looking for that information. I encourage you to take a look at that video. All right, so for patient responsibility, the patient does have cost sharing, so their deductible and coinsurance do apply. And it may be a good idea to let the patient know that you're billing for this. While you are not required to notify patients about G2211, so you do not need an advanced beneficiary notice or an ABN, since G2211 is a covered add-on code. But communicating this information up front might be a best practice to help your patients understand and avoid any surprises really when they see their bill. Next, we want to talk about Modifier 25 as it relates to billing this code. Modifier 25 is used for E&M services that are significant and separately identifiable from another procedure or service you report on the same date of service. And this could be a surgical procedure, for example, or an injection procedure code. It could be where you're using Modifier 25 for a significant and separately identifiable E&M service the same day as an annual wellness visit. And these are just a few examples. You'll want to make sure that you're using Modifier 25 correctly. You would not use Modifier 25 on G2211, as G2211 does not require the use of any modifiers. G2211 would not be payable when the associated E&M visit is billed with Modifier 25, except in certain situations, which we have on the next slide. So here we have Modifier 25 exceptions. We did have several pre-submitted questions regarding the billing of G2211 when the E&M code is billed with Modifier 25. Again, G2211 would not be payable when the associated E&M code was billed with modifier 25, but with some exceptions. Effective for dates of service on or after January 1st of 2025, G2211 may be billed in addition to a medically necessary E&M code with modifier 25 only when the service requiring the reporting of modifier 25 is a Part B preventive service, immunization administration, or an annual wellness visit. And there is a complete list of allowed services that fall under this exception, and you can find that in the article I have linked on this slide. I'm actually going to pull that article up now to show you. All right, so if you were to click on the link from that slide, which was slide 19, it would take you to this page that you should be seeing now. And there's some great information on G2211 in this article, but what I want to show you for modifier 25 exceptions is on page 4. So here we see this section titled CR 13705 changes effective January 1st, 2025, which is where it tells us that the exception includes those 3 items I had listed on the slide, which are the preventive services, immunization administrations, and annual wellness visits. Now right here, you see attachment 1, and I'm going to go ahead and click on this link for attachment 1. Now, if any of the services on this list are billed the same day as the E&M service, meaning this is the service requiring use of modifier 25 on your E&M service, only then would G2211 be payable in a modifier 25 situation. Let's give an example. Say you're reporting modifier 25 on your E&M service that is significant and separately identifiable from an annual wellness visit, code G0438. If that code is on this list, then G2211 could still be payable even though the E&M service is reported with modifier 25. So I'll do a quick search. I'm going to hold down the Control and F key, and I'm going to type in that code, G0438. Since it is listed here, that means G2211 is billable in our scenario. Now, one question submitted with registration asked why you can't bill G2211 with the flu and pneumonia administration codes. The flu and pneumonia vaccine administration codes, G0008 and G009, are both on this list. So G2211 is payable in addition to your E&M service billed with modifier 25 when a flu or pneumonia administration was done the same day. So make sure to check this list for the code that you're billing to determine if the add-on code is payable when your E&M service has modifier 25. Now, if your service requiring the use of modifier 25 is not on this list, G2211 would not be payable. So for example, if you reported modifier 25 on your significant and separately identifiable E&M service because your provider performed, let's say, destruction of skin lesions the same day, and let's say they've billed that with code 17004. You could search for that code. So I'll do a search for 17004, and that's not on our list. So the codes on this list again, these are all Part B preventive services, immunization administrations, and annual wellness visits. So in our second scenario with the skin lesions, when the E&M service is billed with modifier 25, G2211 would not be payable. One last thing before I head back over to the presentation. You may have noticed here that when I searched for that last code, it came up to this page here, which doesn't really look like our list, right? That attachment that I've been talking about is actually part of the change request, or CR 13705, which is what announced this modifier 25 exception. I just thought I might point that out if anyone was confused as to why this doesn't look like our list. The list actually begins on page 9 of this change request. So if I put in my page number, page 9, that'll take us back down to our list. All right, let's head back to the presentation. We did have a few pre-submitted questions asking about documentation requirements for this code. First, you will need to document the reason for billing the associated E&M visit. So the visit itself must be medically necessary in order to report the add-on code G2211. The documentation must demonstrate medical necessity of the actual E&M visit and must support the level of service chosen for that E&M visit. For G2211, there are not any additional documentation requirements, but medical reviewers may use the medical record to verify medical necessity of the visit and accuracy of reporting G2211. So documentation to support billing this code could include the length of time that you've been treating the patient. It could be documentation of patient contacts with you between visits, documentation of your coordination with other providers involved in that patient's care. This could also include information in the medical record or in the claims history for the practitioner and patient history. This could be documentation that you're treating a single serious or a complex condition. We received several questions asking about whether certain diagnoses are considered single serious conditions. Again, there's not an all-inclusive list of approved diagnoses because the code isn't driven just by the condition. It's driven also by the expertise required to manage it. CMS stated that the management of that serious or complex condition must require the direction of a practitioner with specialized clinical knowledge, skill, and experience. So if a nurse reviewer reads your documentation, will they understand why your provider's expertise was needed to treat that condition? Meaning, don't just document the condition, but the documentation should also show how your provider's expertise is used in managing the treatment of the single serious or complex condition. Remember that you must have documentation of that longitudinal relationship with the patient. So you want to look at the documentation and make sure that it's clear the practitioner has or intends to have for your new patients a long-term ongoing relationship to care for that patient. So you could make a note or an attestation statement. For example, you might note that you've been treating this patient for the past 15 years or the past year or whatever the case might be. We were also asked if we have any audit results for this code. And the answer to that is no. While we do not have results from any medical review audits at this time, I will be sharing some claims data here in a few slides, which will include some top reasons that G2211 claims are rejecting and denying. So this code can be submitted by a teaching physician when present during the encounter if the teaching physician guidelines are met and the E&M code is billed with modifier GC. This code may also be billed under the primary care exception when modifier GE is billed with your lower level E&M codes if the requirements for G2211 are met. Now, you would not append modifier GE or GC to this code. Again, G2211 does not require the use of any modifiers. And we did also include a link here on this slide for a reference on teaching physician guidelines, since we're not really going into detail on that topic today. All right, next, we did have some questions asking if G2211 may be billed with telehealth visits. So G2211 can be billed when the primary E&M service was performed via telehealth. This would only apply if the service provided is appropriate for telehealth, and you can determine that by checking the CMS list of telehealth services. So let's go out and take a quick look at that. If you click on the link that I provided on slide 17, or you can even go to the CMS website, cms.gov, and if you type telehealth list into the search, this should be your first search result. So from this page, you'll want to click on the second link here, the list of telehealth services for calendar year 2026, which will prompt you to download a zip file, which I've already done. Now, once it's downloaded and you open up that zip file, you'll find the Excel and text files. And you can open whichever format you prefer. They do contain the same information, but my preference is to open the Excel file. And I've already opened that up in preparation for today's event because it can sometimes take a minute or so to load. So here you can do a search for your evaluation and management code. So I'm going to do another Control F. And I'm going to look for code 99202 and press enter. There we go. You can see here that the code is on the list, actually along with all of the other office and outpatient codes right here, meaning these are appropriate services to be done via telehealth. Now, just for fun, I'm going to do one more search here. I'm going to do G2211. And there we go. You can see G2211 is on the list as well. But I do encourage you to check this list to make sure that whatever service you're providing is acceptable via telehealth. All right, I'm going to head back to our presentation. We are not going into any more detail today on telehealth, but Leanne and I are doing a two-part series on telehealth at the end of this month, and registration is still open. And Leanne will be placing links in the chat to register for those webinars. All right, on this slide, I have included a few resources. First, we have a resource on how to use the office and outpatient E&M visit complexity add-on code, G2211. This covers a lot of what I've gone over today and includes some background information on the code. And then this also includes the information on that exception for E&M services reported with modifier 25. Next here we have the CMS FAQ, and this addresses several of the questions that I've gone over today. Next, change request 13705. This again is the official notice for those changes to allow G2211 when the associated E&M code is billed with modifier 25 for certain services. And then the last thing we have here is the Claims Processing Manual, Chapter 12, which I mentioned early in the presentation, and that's where you would find that full official definition of this code. All right, next I do want to share some claims data for G2211. First, for G2211 claims data, I wanted to share these numbers with you. I pulled this data when I put this presentation together back in mid-January for claims that were submitted to J5 and to J8 between July 1st and December 31st of last year. And there were a total of about 2.1 million G2211 claims submitted during that time. Of those, over 1.9 million paid, which was about 93% of those claims submitted. And that's fantastic news. We absolutely want to see your claims paid appropriately. I did also take a look at some data that was presented when we first started providing education on this code, when it was first payable by Medicare back in 2024. And at that time, we had about 83% of G2211 claims paid, compared to 93% from this data pool. So we've really come a long way. For denials, we had about 124,000 deny, only about 6%. And then lastly, there were about 15,000 claims rejected during that time period, which accounted for only about 1% of the G2211 claims submitted. All right, so on this slide, we've included the top denials for G2211 for that same time period. The first denial we had for G2211 was not payable with other services rendered on the same date of service. So remember we talked earlier about Modifier 25? This could happen if the related E&M service was billed with Modifier 25, but does not fall under one of those exceptions. So this could be like our example, when the E&M service was billed with Modifier 25, and then we had the destruction of skin lesions done, and we found in that case that G2211 would not have been payable because it didn't fall on that list of exceptions. Our next denial is must be billed with a primary service. So G2211 is an add-on code. It does not stand alone. So it must be billed along with one of those primary E&M codes we looked at on slide 5. Next, we have duplicate charges. This would happen if payment was already made to you for G2211 for that patient on that date of service. Now, if you believe your claim denied duplicate and error, you are able to submit an appeal. Lastly, we have claims denied while the beneficiary is in a period of managed care. And this would happen when they're enrolled in a Medicare Advantage plan. So make sure that you check eligibility. And if they do have a Medicare Advantage plan, the claim must be billed to that plan. Original or fee-for-service Medicare does not process those claims. There's also a link to a page on our website here for information on some common claim denials, which does include each of these top 4 G2211 denials. Next, we have the top rejections we saw for G2211. Our first rejection here is claim lacks information needed for adjudication. So something is missing from the claim. And this could be any of the items that are required for that claim to process, such as the patient's date of birth or your place of service, for example. So you'll want to double check your claim form and make sure that you have all of the required elements included and resubmit your claim. The next one on our list is missing, incomplete, or invalid place of service. So we looked at those eligible places of service on slide 10, which were those that apply for your outpatient E&M codes and also your home visit E&M codes. So to give an example for this one, if your place of service is 21 for inpatient hospital, G2211 is going to reject this way. Next, we have unable to obtain primary insurer information. For this, you may want to check item 11 on your 1500 claim form. That's a required field. So you must include other insurance primary to Medicare in that field. And if there is no insurance primary to Medicare, you would enter the word none. Leaving that blank on a paper claim form would cause your claim to reject this way. Now, for your 837P electronic transactions, make sure that you're including the primary insurance policy number. But if there's not insurance primary to Medicare, you would actually leave this blank for your electronic claims. Okay. For the last rejection here, we have rendering physician number invalid or missing. For these, double check that you've included the physician's NPI and that it's the correct NPI, and then resubmit the claim. I did include a link on this slide, which is to an article on our website, not necessarily specific to G2211, but you could use this one to help with really any of your rejected claims, not limited to just G2211. Excuse me for just a moment. I have a tickle. I made it almost all the way through. All right, sorry about that. All right, I've included this slide here as a reference to kind of help summarize what I just talked about for the G2211 denials and rejections. For your rejections, you will fix the error and resubmit the claim. Remember that for rejections, the claim was not able to fully process, meaning a claim determination was not yet made, and the claim does not have appeal rights. Those must be corrected and resubmitted. For denials, your next step will depend on the type of denial you receive. Your remittance advice will really be your best source to determine what's next. It might indicate that you need to resubmit your claim, in which case you can correct the error and resubmit. In some cases, though, you may be able to correct a minor error through a clerical error reopening using our SecureNet Access portal. And this might be a keying error for your place of service or your rendering provider's NPI, for example. And then you'll have denials that will require you to appeal if you disagree with the claim determination. And your remittance advice would include the remark code MA01, which indicates that you have appeal rights. And then I did also include a link in the last bullet on this slide, which has some information on how to appeal a claim if you're a little newer to Medicare and need some help with that. We have one more pre-submitted question that I'd like to address here, which asked for examples of when to use this besides the ones published in the Federal Register. While we do have to follow that guidance, there are so many situations where this code could be applicable based on the cognitive load required to manage that patient's condition. So it's about the relationship with that patient, not necessarily the complexity of the visit. So you might be a primary care provider, and let's say Betty has been your patient for 10 years. And she comes in complaining of feeling just overly tired. Because of the relationship with Betty and the cognitive load involved in reviewing her history in the context of the 10 years you've spent providing care for Betty and your understanding of certain risk factors, G2211 might be billed because you have that long-term relationship and you are the focal point of her healthcare. Or you might have an oncologist who has been treating Patty's breast cancer for 5 years. So she comes into the oncologist for her routine 6-month checkup, where the oncologist reviews her symptoms, performs an exam, and does a medication check. G2211 might be billed because the oncologist has the ongoing long-term relationship with Patty and has been providing that ongoing care to treat her single serious condition, the breast cancer. Or let's talk about a complex condition. Maybe a psychiatrist has been treating Bobby's schizophrenia for 3 years, and the psychiatrist performs a brief exam and a prescription refill. Even though the visit is short, the psychiatrist is managing a complex condition, the schizophrenia, and they might bill G2211 in addition to the E&M code if the documentation supports it. So in each of these examples, meeting the requirements to bill G2211, again, is not in the complexity of the visit itself, but it's based on the provider's relationship with that patient, where they have the cognitive load in caring for that patient. So a provider who did not have that relationship, they would not have that same cognitive load in treating any of the patients in these examples. So documenting that ongoing relationship is really essential in showing that the requirements for this code have been met. All right, I see we are almost to the top of the hour. Out of respect for everyone's time, I'm not going to get to live chat questions today, but please don't worry. I will send out an email to all who attended today with answers to any unanswered chat questions. If you do think of any additional questions, you have 7 days from today to submit those. And you'll send those to our education mailbox, and make sure to include the title of the webinar, which was E&M Add-on Complexity Code G2211, and you'll put that in the subject line so that they make sure those emails come to Leanne and I. Please keep in mind, though, again, I am not able to access any claims history, so you will want to contact customer service for any claims-related questions. In a few minutes, you will receive an email to thank you for attending, and you don't want to delete this one without reading it. This email does contain your certificate of achievement, so it'll have your name and contact hours if you need to turn that in for credit towards continuing education units. Now, if you do not receive the email, a few things may have happened. First, you may want to check your spam or junk folder. Also, be sure to add messenger@webex.com to your safe sender list so that any future messages would show up in your inbox. Also, if you joined by phone only, you would not have received this email, as there's not a way for us to capture your email systematically from our attendance record, but no need to worry. If you join by phone, you are able to email us with the phone number that you joined with to request your certificate of attendance. And Leanne will be adding that email address to the chat. All right, last thing I have for you, please do take a few minutes to complete our survey. Tell us what you liked, what we can do better, and suggest topics for future education. There are different options to take the survey. You can use the link in the chat, or when you exit today, you'll be prompted to go to an external site, and that external site is the CMS Qualtrics page. The prompt will look like the picture we have shown here with the little yellow triangle, and we included that image on the top right of this slide so that you know this is safe. This is not malware or anything like that. For those listening through our website or through YouTube, you also have the same opportunity to provide feedback. You will have a survey card at the end of the presentation. All right, that does conclude our webinar. On behalf of myself, Leanne, and all of Provider Outreach, we thank you so much for taking the time to join us. We look forward to your survey feedback, and we hope to see you again at future events. Everyone stay warm and have a wonderful afternoon. You may now disconnect.